Welcome to ADAPT NCLEX. Thank you for deciding to watch this video. We're going to talk about furosemide and the electrolyte deficiency associated with this. Is a key concept you're supposed to know, good medication you're supposed to know. I'll talk about the pathophysiology associated with this medication and some of the things the NCLEX will ask you that you never know, especially other things associated with it. I know everybody know about potassium, but there's something, other things you're supposed to know for your NCLEX. So we're going to focus on that, and I'll give you the pathophysiology. Just know that this is a loop diuretic. What does that mean? That means it's going to act a certain way or a certain portion of the nephron, and that's why we call it a loop diuretic. So a loop diuretic, and then it works on the loop of Ellen. And I'll show you what it means by that. Loop of Ellen of the kidney or in the kidney, right? In the kidney. And what is that? What does it do? It usually prevents reabsorption, okay, reabsorption of certain electrolytes, sodium, potassium, magnesium, okay, and water. These are the key, and sometimes chloride, right? Chloride. These are electrolytes that usually get affected by furosemide. What am I talking about? So if you remember your uh, nursing school lectures, these are something we call Bowman's capsule. This is the nephron. The nephron has a Bowman's capsule, right? Um, and the capsule basically has a glomerulus that comes in with the afferent arterial. This is the afferent arterial. This is efferent arterial, bringing blood that get filtered. And the capsule, it change into what we call collecting and proximal collecting tubule, like that. Then it form the loop. It's like a H loop of Ellen, come like that, like a U, and this is the distal collecting tubule, and then it turn into the collecting duct. This is where urine is almost made, completely made, and it comes out. And so this is the afferent arterial, this is the efferent arterial, and this is the capsule that the glomerular is going to that. This is the loop of Ellen. This is the descending aspect. This is the ascending aspect. And it's these segments that is responsible for all the changes that we'll be talking about. So I'll come back to this picture, and then we'll go through them in terms of what you need to know for your NCLEX. So let's get to it. First of all, you have to know what is the usage of these medication. Everybody knows about it. The most common usage um, is basically for edema. Edema associated with what? Heart failure, right? Or liver disease or kidney disease. That is the most common way these medications are usually utilized to get rid of fluid. The second is hypertension. If other medication doesn't work, we can go and utilize this medication to get rid of fluid. The key thing I want you to know is the mechanism. There is electrolytes that it causes, right? It leads to low um, sodium. It leads to low potassium. It leads to low magnesium. It leads to high glucose. It leads to high uric acid. So this is the key question that was posted to me. These are all electrolyte abnormalities that it can lead to dehydration, so low water. And then you want to figure out how does this happen? And let's take one at a time. So sodium, the key, the total effect is low sodium. Some of them may be dilutional sodium. And how does that happen? And listen carefully because this is the key concept you have to be familiar with. This is what I want to be familiar with. So this is the issue with this. So this is the urine coming through the bone capsule, proximal covalent tube. Then it get to the loop of Allen, descending, and then when it get to the ascending, there is a channel we call it sodium, potassium, K chloride channel. This is chloride channel. So it's a sodium potassium chloride channel. It's responsible for reabsorption of sodium, potassium, and chloride. And what furosemide does is it blocks this channel such that you cannot absorb this in addition to water because you're not absorbing sodium. In the process, you have a large amount of sodium, chloride, potassium, water going through the distal convoluted tube and then finally into the collecting duct. So most of this will go into urine without not you reabsorbing. So we lost a bunch of sodium. The good thing is this is what happened. Your body will recognize that you're losing a lot of water. So when the fluid gets to the collecting tubule, you have renal angiotensin system activated. You have ADH activated to absorb more water so that you cannot get sick. Then what happened? If you have renal RAS system activated, what is get activated? Aldosterone. This aldosterone leads to water and sodium retention, and they lead to what? Loss of potassium in the. Unfortunately, you cannot absorb all the sodium. The renal angiotensin system cannot completely compensate the large amount of sodium and water being deposited in the collecting tubule. So they can absorb some of them, but not all of them. Therefore, it become a problem. You losing sodium. In the process, you release more ADH in order to what? Get more water, more fluid, because you're losing water. The kidney is getting rid of fluid through furosemide, the water. In the process, if you release ADH, you're going to what? You're going to absorb what? More water. What does the water do? Water retention. It will dilute the sodium and you have dilutional hyponatremia. In effect, you've effectively lost sodium through dilutional and lost sodium too large amounts in the urine, even though the renin angiotensin system is still being taken in the working. And this is the effect. That's why we use furosemide in HCHF. You don't want to absorb too much sodium, then it become um, counterintuitive. Why using furosemide to get rid of fluid and then in the process retaining more sodium? No, it doesn't. It causes hyponatremia, not hypernatremia. So low sodium associated with that. Your board does not focus too much about it. It focuses about dehydration. When he's talking about dehydration, he's talking about low sodium. So that is the effect of sodium. That's the key. The potassium, as you can see, is the same thing, the same idea. We have lack of potassium absorption at the ascending loop of Allen. Here, the pump is, we call it sodium, potassium chloride channel. So this is it's a big channel. It's responsible for basically absorption of sodium and then potassium and chloride channel. So because of that, you're losing all of that. When the fluid get to the collecting duct, I told you, as the RAS system get activated, the RAS get activated, the aldosterone leads to more loss of potassium. Aldosterone hate potassium, so you lose more potassium. And this, in effect, leads to extreme loss of potassium compared to sodium. That's why we talk more about it. So there's more potassium loss. So potassium loss is greater than sodium loss. So your board talks about loss of potassium. So this is what I want you to understand in terms of the whole process of the RAS system, and then the potassium and sodium loss. So this is the way the whole process works. And the kidney will try to compensate, but it cannot do that. So this is where the information is all related in terms of the pathophysiology. The same system that I talk about can lead to what? Hypomagnesia. This is hypomagnesia. The pump sodium, potassium to chloride channel, it creates a positive gradient. And this leads to reabsorption, okay, of calcium and magnesium, especially magnesium. And so when furosemide block this channel, you have what? Loss of magnesium. That's why the magnesium level is also very low. The next thing your board may ask you is glucose. So hyperglycemia. How does it happen? The first thing is I told you furosemide leads to what? Hypokalemia. So hypokalemia. Remember, when your potassium is very high, you're going to release what? Insulin. When insulin get released, it causes what? Hypoglycemia. So in this, so when your potassium is very high, you release insulin to get rid of it. So high what? Potassium will lead to what? Insulin release. Insulin release will lead to what? Low glucose. Well, when your potassium is low, what do you think? It's the opposite. You're not going to release insulin. In the process, your glucose go up. And that's what happened. The second mechanism is for you to know is related to basically stress, right? When you lose a lot of fluid, your body does not like it. So a large amount of fluid loss. What do you think? Your body does not like it. It thinks you dehydrated. Your blood pressure is going down. It releases stress hormone. Or the RAS system also release stress hormones. These stress hormones like cortisol, and that increases your glucose. So this is why it causes hyperglycemia. The last one that I want you to know is uric acid. It affects uric acid reabsorption. So furosemide do the same thing. It releases large amount of uric acid in the collecting duct, and then it lead to lack of absorption into the or lack of excretion of that of uric acid, and this get absorbed into the body and then increases uric acid in your blood. So you have hyperuricemia, and that can lead to gout. So excessive use of furosemide they will create these conditions. And um, in summary, you have to know furosemide, what it causes increase what? Uric acid, increase glucose, low potassium, sodium, and magnesium. and magnesium. So your board will ask you this. Other key things you're supposed to know about this medication is before you give it to any patient, administration, you got to check their vitals. You got to check the blood pressure because they can be hypotensive, loss of fluid, right? You got to check a baseline and BMP, which will give you their potassium, their magnesium, and their sodium. You have to check their kidney function. It can affect your kidney initially, so you got to check their creatinine level. It's very, very important. When during administration, right? During administration, there's certain things you have to know. You have to assess how much they respond to that. So how much urine output came out, right? You have to assess their potassium level and whether it's going down, right? And then you look for signs and symptoms of weakness, look for signs and symptoms of muscle cramps, this is a drawing and after, right? During and after. Then you look for signs of muscle cramps. All those things are very, very important because that's what your board may ask you. You look for signs of dehydration, like skin turgor is poor, and hypotension. Um, there is certain things you have to know that is a little bit additional information. You'll see it in questions, and then you want to figure out why this is happening. Why are they asking you? Most of the time, it's related to some small adverse effect, and that is your hearing or toxicity, right? And this is usually happening when you're administering the medication via IV. So if you give it too fast, the patient will have hearing problem. The best thing to do is to slow down the rate. When you see a question like that, yeah, slow down the rate as much as possible, and then that may help. You don't have to stop the medication. The patient may complain, and all you need to do is just stop the medication. Administer it slowly as much as possible. It's better to administer it over 1 to 2 minutes. It's very good. Slowly, I will push instead of too fast, right? There's other things you have to know to drug interaction, right? It's very important. These medication, if you take late NSAIDs, it defeat the purpose. So it reduce the effectiveness of furosemide because we're trying to get rid of water and sodium. NSAID will lead to water retention and sodium. So that's a problem. It also increases toxicity of digoxin. So because of the hypokalemia, it's all related to that. So these two medication, when you're furosemide, you should try to avoid taking them as much as possible. Of course, you will have to teach the patient because of the education associated with your NCLEX really like very much. Education is always key. Is the potassium rich diet. They should stay on it, right? They should report signs of hypokalemia. Potassium rich is like maybe banana, right? Or I call it the fast, right? But the easy way is banana, spinach, some oranges, potatoes. These are all very good source of strawberry is also good. Tomato is also good. Source of a potassium when a patient is on this medication, you have to teach them. You have to make sure they're wearing the same at the same time, wearing the same clothes, in order to check what is going on. But this is just a summary of things that they may ask you. One more thing before I leave, priority function. Once again, I told you hypokalemia is the key. But if they give you the Steven-Johnson syndrome, remember, this is a sulfur drug. Sulfur drug causes photosensitivity and Steven-Johnson syndrome. These two side effects are very classic. They are your board favorite and your B-sharp moment. Hypokalemia and Stevie-Johnson syndrome for furosemide are the key. So when you see hypokalemia, you see hyponatremia, you see hypomagnesium, you see hyperglycemia, the most important is hypokalemia. This is furosemide. This is the pathophysiology associated with all the things you see associated with it. Take care of yourself and good luck.